I'm very excited to share with you what we've been learning about cannabis use during pregnancy. And we're going to be talking about research all the way from policy to practice today. And one of the things that tells us why this topic is so important is this recent report that came out from the American Heart Association that identified two periods of time that we really need to be the most concerned about in terms of the potential negative impacts of cannabis on the brain. And so those two periods of time are early THC exposure in utero and also THC exposure during adolescence. And we now know that there is growing evidence that cannabis use during pregnancy is associated with negative outcomes for moms and their babies. And we think that this might be particularly true in more recent years because we know that the strength of the products that are being sold today has increased. And so, due to these concerns about the potential health risks, the American College of Obstetricians and Gynecologists says women who are pregnant or contemplating pregnancy should be encouraged to discontinue marijuana use, and those reporting marijuana use should be counseled about concerns regarding the potential adverse health consequences of continued use during pregnancy. However, surprisingly little was known, especially at the time that we started doing this work, about trends in prenatal cannabis use. We really didn't know a lot about why people are using cannabis during pregnancy. There wasn't as much evidence about the health impacts and a lot of confusion, and clinicians really just aren't sure how to talk to pregnant patients about their cannabis use during pregnancy. And so our work that we've done over about the past 10 years has really set out to try to address these gaps in knowledge. And the work that I'll be presenting today takes place in Kaiser Permanente, Northern California. So if you're not familiar with us, we're a large integrated healthcare delivery system serving about 4.6 million members in the Northern California region. We have more than 50,000 pregnancies a year. And our patient population is very diverse and representative of just the general Northern California population with access to care. We also have integrated care and a robust electronic health record system, which is useful for our patients, but also allows us to do some really interesting research. And then we also have what's called our KPNC Early Start Program. And this is an award-winning perinatal substance use screening and intervention program. And it's unique because it's directly integrated into prenatal care. And so we know that oftentimes women who are using substances during pregnancy don't want to go to specialty addiction medicine treatment, or maybe don't have levels of a concern that require them to go to specialty treatment. But we are able to bring the prenatal substance use intervention directly to them. And so the way this works is that there's universal screening for substance use at entrance to prenatal care. We ask our patients both to self-report on their frequency of use of a variety of substances since pregnancy. And then they're also given a urine toxicology test to which they consent. And then patients who screen positive for using substances during pregnancy are not penalized or punished. They're given further assessment to try to understand sort of how much they're using and what their reasons for using are. They're provided with education about the potential risks, and they're also offered counseling that's directly integrated into their prenatal care. So they can come see their OB/GYN and then walk down the hallway and meet with their early start specialist who talks a lot about substance use in pregnancy, but is also there to support the patient with their mental health and other things. They're all licensed mental health professionals. And so this program is really designed as a clinical program meant to help our patients, but it also provides really rich data that we're able to use for research as well. And so I thought it'd be fun today to tell you about both our quantitative studies using this electronic health record-based large data sets on pregnancies and KPNC. And then I'll also be sharing some of our qualitative work that was based on focus groups that we did with 53 pregnant patients who used cannabis during early pregnancy. These were done in late 2021. And the reason that I want to do this is because too often research is really conducted on and about people rather than being inclusive of the people who are being studied. And so we wanted to remedy this gap by conducting focus groups to hear directly from these patients, and then I can bring their voices into the presentation. All right, so my goal today is to tell you what we've been learning about trends in prenatal cannabis use. We'll talk about why pregnant people might use cannabis. We'll talk about what we know about the health risks, and then we'll end with a discussion of how to talk to patients about cannabis use during pregnancy, and we'll have time for questions at the end. All right, so let's get into what we know about trends. So when we first started doing this work, we had heard anecdotally from our clinicians that they were seeing increases in the percentage of patients who were using cannabis during pregnancy. And there had been a paper that came out using national US data that showed that self-reported use of cannabis in pregnancy had been increasing over time. And we said, well, hey, we can do that same study using data from KPMC, but not only do we have the self-reported data, we also have information from our universal toxicology testing. And so that will be interesting to compare. So this was our first paper that we published back in 2017 in JAMA. And what we found was that between 2009 to 2016, prenatal cannabis use nearly doubled. So that's if you look overall, if you screen positive by self-report or toxicology test, that's shown here in black. But what we also thought was interesting was that over twice as many people were identified by toxicology testing, shown here in blue, as compared to self-report, shown in orange. And to us, this was very informative because what it indicates is that we think that maybe the prevalence of true cannabis use in pregnancy is much higher than what we had previously thought based on other data sets, which are really based only on surveys. We also wanted to look at trends over time by different age groups. And so here you can see that our youngest patients, less than 18 and 18 to 24, are more likely to use cannabis during pregnancy across years, so substantially more likely. But we also found that the rates of increase were actually fastest. And so this was concerning to us. So the next question we had was, okay, well, now we know that any use is increasing over time, but is the frequency with which patients use cannabis in pregnancy changing over time? So this was a paper that we published in JAMA Network Open, and here we were limited to self-reported data because unfortunately our toxicology tests don't give us any information about frequency of use. So we relied on what people told us about their frequency of cannabis use during pregnancy. And what was interesting to us is that we found that the annual relative rates of change in daily, weekly, and monthly or less prenatal cannabis use all increased significantly over time. So basically all frequencies were increasing as time went on. But what was concerning to us was that daily cannabis use was increasing most rapidly. Okay. And if you look at this another way, what we saw was that in 2009, among people who said they used cannabis during pregnancy, 14% reported that they used every single day. And by 2017, this went up to 21%. And I can tell you that by 2021, this percentage of daily use has increased to 32%. So nearly a third of our patients who say they're using cannabis during pregnancy are using every single day. And it's really important to understand this increase in daily use within the context of this extraordinary increase in cannabis strength. And so the primary intoxicant, as I mentioned, is THC. And we know that the strength of THC in products has tripled over the past couple of decades. So we have more people using daily and higher strength products. And so this paper received a lot of media attention. The US Surgeon General actually tweeted about this study, and he included it in his advisory in 2019 about the harms of cannabis use during pregnancy and in adolescence. And when we talked to pregnant patients about what they've seen in terms of changes in use over time, we heard so many stories that complemented what we were seeing in our data. So this patient says, like 5 years ago, if you smoked weed while pregnant, people would be looking at you like, you're crazy. Like, what are you doing? They're like, who sold a pregnant person some weed? Now it's like you might just see a group of pregnant people passing the blunt around like, okay, like y'all smoking, okay. So the next question we had was whether rates of prenatal cannabis use might be increasing faster among people who are not using other substances. And the reason that we hypothesized this is that we were seeing more people using cannabis who were very healthy, maybe otherwise would not touch any other substances. They sort of said to us, don't even ask us about cannabis in the place with other substance use because it's not a substance and it should be in a separate section. And we were finding that some of the people who are using cannabis in pregnancy are very healthy in other ways. And so we thought that as people perceive it as natural and safe, more people might be using cannabis only who wouldn't use other substances. And this is important because traditionally, it's been very challenging to study what the health risks of cannabis in pregnancy are, because there's this idea that people who use cannabis in pregnancy are also using lots of other substances, and it's hard to tease apart what's truly due to the cannabis. And so we looked into this. This was a paper that we published in JAMA Network Open in 2022. And what we found was quite interesting. So we see here that the percentage of patients who use cannabis during pregnancy, the proportion of them who are only using cannabis is the largest. And so you can see that line here in black. So this is patients who are using cannabis only and nothing else. And then underneath it, you see cannabis and use of one other substance, or cannabis and use of two or more other substances, which in fact, cannabis and use of two or more other substances was going down over time. And not only was cannabis only most prevalent, but the rate of increase was fastest in this group. So this is consistent with what we had hypothesized. We also looked at co-use of cannabis with specific substances. So here again, you see that cannabis only line, and then you can see that cannabis and nicotine, cannabis and stimulants, and cannabis and pharmaceutical opioids are actually all going down significantly over time. And the one exception was that cannabis and alcohol use during pregnancy was going up slightly. And so this is really consistent with this term California sober, which you may have heard of, which is used to describe people who decide to quit consuming drugs and alcohol with the exception of cannabis. And again, when we talked to our pregnant patients, we heard themes that were very consistent with our quantitative findings, with patients saying things like, I don't do drugs, I don't take cocaine, I don't do heroin, I don't do methamphetamine, do I smoke marijuana? Yeah, sure I do, of course. And this was a person who was talking about her use during pregnancy. So next, of course, with the pandemic, we were very curious to see how that impacted rates of cannabis use. I myself was pregnant with my second son had him in July of 2020. So I'm familiar with what it's like to be pregnant during the pandemic. And we were fortunate to be able to get a competitive revision from NIDA to one of the grants that we had to study the impact of COVID on prenatal cannabis use. And this is a research letter that we published in JAMA in 2021. And so what we did here is we used an interrupted time series analysis, and we compared the first 15 months prior to the pandemic to the first 9 months after the pandemic. So this is pretty early in the pandemic that we're looking. And what we found was that there was a 25% increase in prenatal cannabis use that occurred during this early period of the pandemic. And this was based on urine toxicology testing. So our patients, even during the pandemic, still continued to come in for that first prenatal visit and receive the toxicology testing. And so this is based on biochemically verified data that we had in a sample of over 100,000 pregnant patients. We see this jump in use that occurred during the early pandemic. And when we talked to our patients, we heard a lot of themes consistent with this. This is an example of one patient who said, I think the pandemic does increase the use of cannabis during pregnancy. People are very anxious and going stir crazy. They're stuck in the house and then finding out, oh, I'm pregnant, and all of these things I would have wanted to do during pregnancy, I can't do. So becoming a coping mechanism. And when we think about this, I really think it highlights the importance of linking pregnant people to resources during time periods of stress, right? Because we know that patients are turning to cannabis as a way to reduce stress or try to cope with stress. And so just a reminder that we need to give extra support to pregnant people to help them with their stress and mental health. So more recently, this was a paper that we just published near the end of 2024, and we were curious to know whether there were socio-demographic differences in prenatal cannabis use and in rates of change of use over time. And so what we found here was that the prevalence of prenatal cannabis use increased from 5.5% in 2012 to 9% in 2022. So about nearly 10% of our patients are screening positive for cannabis in pregnancy as of 2022. And what we found was that the increase actually varied significantly across racial and ethnic groups and across age groups. So there's two things I want to point out. First, you can see that there are substantial differences in the prevalence of prenatal cannabis use by race and ethnicity and by age group, with the highest prevalence in our Black patients and our younger patients aged 13 to 24. However, we saw that the rate of increase between 2012 and 2022 was actually higher for our patients who had a lower prevalence to begin with. So the prevalence is increasing faster among those who have the lower prevalence to start with, but even so, you can see that in 2022, there are still striking disparities in use of cannabis during pregnancy. So we are still seeing and continuing to see these differences across groups. All right, so let's switch gears now. I want to talk a little bit about why we think people might be using cannabis during pregnancy. And this is really important because I want to highlight that pregnant people want information. They're asking their clinicians about what the harms are of cannabis use during pregnancy, and studies show that oftentimes clinicians don't really know or offer little response. And many pregnant people perceive that there's little to no harm to their baby. And so it's not, that we know that pregnant people are in general trying to make positive decisions. They're trying to do what's right for themselves and their child. And there's just a lot of misinformation out there. And so what we're seeing is that pregnant people are then searching online, they're asking family and friends and social media, where they frequently receive incomplete information that's suggesting that cannabis use during pregnancy is safe and effective for treating pregnancy-related symptoms. And there's also so many online community forums that are really supportive of use. And so these are the types of things that patients are turning to. Now, if you've been pregnant, you may know of the What to Expect website, which is sort of the go-to website for everything pregnancy related. And within this website, there's a group called Ganja Mamas, which is just pregnant people and moms who are looking for information about cannabis use during pregnancy. Oftentimes they're seeking advice, asking questions about the safety of use. They're talking about their reasons for use and sometimes talking about their concerns about drug testing and potential legal consequences, with some people even saying, hey, here's the number for my hospital. Can you call and find out if they drug test? And I want to share this example of one of the threads on this website because it gives you a good sense of the kinds of information that are being shared there. So this mom says, moms that use their whole pregnancy. And she says, I'm just wondering how many of you used your whole pregnancy up until labor? How did it go? Was your baby healthy? And someone else responds and says, I smoked every day, pretty much all day, up until hours before I gave birth. My son is perfectly healthy, gaining weight great, eats great, exclusively breastfed, and has no problems at all. He's 15 days old today. And another mom responds and says, oh, how beautiful. Thank you for posting. It makes me feel better about my choice to use cannabis as well. Baby girl kicks and dances and is growing healthier every day. And so you can see here that these are people who are they care about the health of their baby. They're asking the questions, is it safe? And, I love that the second mom says, her baby is exclusively breastfed, which sort of highlights what we've been talking about of sometimes people who are using cannabis in pregnancy, really trying hard to have a healthy baby and doing all of these things, but not seeing cannabis as something that's not safe. And the unfortunate thing is, of course, as we'll talk about later, some of the negative health consequences, right, might not show up right away. And so you may not know if there's been a negative impact as of 15 days, but this is the kind of information that's being shared. And so we had heard anecdotally from our patients that many are using cannabis as a way to try to self-medicate morning sickness or to cope with nausea and vomiting in pregnancy. And we know that cannabis has antiemetic properties, so it does help with nausea. But there had been no prior epidemiologic studies that looked at this. And so we wanted to use our data from KPNC to investigate this question. And we published a series of studies looking at this. So what I want to share with you is that in this one study where we looked at pregnant people who were screened in the first trimester of pregnancy, when morning sickness tends to be the worst, they were screened for substance use between 2009 and 2016. And we found that prenatal cannabis use was more common in those who had severe or mild nausea vomiting in pregnancy compared to those who did not have nausea vomiting in pregnancy. And the results from our logistic regression analyses that adjusted for a bunch of different covariates or potential confounders found that those with mild nausea vomiting in pregnancy had more than 2 times greater odds of prenatal cannabis use, and those who had severe nausea vomiting in pregnancy had nearly 4 times greater odds of using cannabis during pregnancy. And again, when we spoke to our patients, we heard from so many of them that they were using for this reason. So this patient says, I had really bad nausea, so they had prescribed everything, and they kept escalating until I got to Zofran. They said, there's all these possible scary side effects. And I was like, yeah, I think I'll just start smoking again because that seems less scary. And another patient says, I suffered from hyperemesis this entire pregnancy. I'd lost around 50 pounds in the first trimester, and cannabis was the only thing that made sure I could eat and take my prenatal vitamins. Now, more recently, we decided to look at whether nausea vomiting in pregnancy was associated with increased cannabis use frequency. So here you can see that as the frequency of cannabis use during pregnancy and even before pregnancy increases, the odds of nausea vomiting in pregnancy increase as well. So on the left side, this is the frequency of cannabis use during the year before pregnancy, and you see this kind of nice dose response association, where as the frequency increases, the likelihood of nausea vomiting increases, both mild and severe. And then on the right side, we see as the frequency of prenatal cannabis use increases, the likelihood of nausea vomiting increases as well. And part of why this is really important is that we know that many pregnant people may experience morning sickness and then turn to cannabis use to try to cope with that morning sickness, like what we've been talking about. But something that's not discussed as much, and this is why we're interested in looking at preconception use and nausea vomiting in pregnancy, is that one of the well-known results of withdrawal from cannabis is nausea. And so what we think is that for some people who are using cannabis very heavily, even prior to pregnancy, and they get pregnant and they try to cut down or quit use, they may experience what they think is morning sickness, when in fact it's just the nausea that comes from the withdrawal from not using cannabis. And for those people, of course, it's going to feel better when you use cannabis, right? Because you're treating the withdrawal. But for those individuals, if they're able to just not go back to cannabis for a week or two, it's possible that their morning sickness may actually go away on its own. And so this is something that's really important to let patients know, especially if they're ones who use really heavily and are trying to cut down, that this morning sickness may actually be the result of cannabis withdrawal. So next, we were curious to know whether prenatal cannabis use would be more common in our patients who have depression and anxiety and trauma. We knew that patients have qualitatively reported using cannabis to try to cope with stress and mood, but at this time, there had been no epidemiologic studies looking at this. And so we decided to look at this question using our large data set in KPMC. Here we had a sample of nearly 200,000 pregnancies screened between 2012 and 2017. And what we found was that compared to women without depressive or anxiety disorders, those who had an anxiety disorder, a depressive disorder, or both had significantly greater odds of using cannabis during pregnancy. So if you look at this vertical line that says 1, anything to the right side of that is increased odds of using cannabis in pregnancy. So we see the same thing when we look at self-reported depression symptoms, so greater odds associated with depression symptoms, and you can see that that increases as the severity of depression increases. We also saw higher odds of prenatal cannabis use in those with a trauma diagnosis and those who had self-reported intimate partner violence during pregnancy. And so thinking about the clinical implications of this, right, we know that some people who use cannabis may be using to try to treat their symptoms of depression and anxiety during pregnancy. But this was a cross-sectional study, and it's also possible that patients who are using cannabis are more likely to become depressed or have anxiety that's sort of induced by the cannabis. And so the direction can go both ways. Now, when we talk to our patients, again, many talked about using for stress and depression. So this patient says, I've had depression and anxiety issues. I've been on medication. I've tried therapy and nothing has worked for me. So I think marijuana has always been a good coping mechanism. And so this really speaks to the need for early screening for prenatal depression and anxiety and trauma and linkage to appropriate interventions. And if we can do that, it might mitigate the risk of using cannabis during pregnancy. So that's something that we really need to be screening for and asking about. So another question we had was whether pregnant individuals are now using cannabis because it's legal in California. And so California legalized cannabis for adult use in 2016, and retailers were allowed to open for adult use in 2018. And so we conducted focus groups to try to answer this question. So we did 90-minute focus groups with 53 patients who reported using cannabis during pregnancy. at the end of 2021, and we had 3 themes that came out of these focus groups related to the impact of legalization. And so the first one was our patients said, yes, absolutely, cannabis use during pregnancy has increased after it became legal for adult use. And one of the reasons is because of greater access and exposure. And so they talked about the easier access. They talked about the availability of retailers in their neighborhoods. Many spoke about the convenience and the discretion of being able to have it delivered. And so, although some people were fine and had no problem walking into a cannabis retailer fully pregnant and visible, others appreciated that they didn't have to do that because they could have it delivered to their home. And they talked about the widespread marketing and advertising and how that had an impact on their use. And so this patient says, you look at the cannabis clubs on the corners, that it's literally like a liquor store here. You know, the easy access, the convenience. And another says, I get text messages from one of the dispensaries that I go to almost every day of their deal of the day, and I always get pissed. I'm like, screw you, you know I can't use cannabis. And this person was really trying hard not to go back to cannabis use during pregnancy and was having so much trouble with these constant reminders of the deal of the day. So I thought that quote was quite powerful. The second theme that came out of these interviews and focus groups was that our patients really thought that now that it's legal for adult use, there's less stigma around prenatal cannabis use. And one of the unintended benefits was that many patients said that now they were more willing to talk with their clinicians about their prenatal cannabis use. And so this patient says, I think that if it wasn't legal and I didn't feel comfortable speaking about it in the beginning with my doctor, I may still be smoking, because if I didn't say anything and didn't have those conversations with my doctor, I probably would have just kept doing it. And this is really interesting, right? Because we ideally want our patients to be talking with clinicians who have information about the safety of prenatal cannabis use. But I will say that, and we'll talk about this more later, in California, prenatal cannabis use does not require reporting to law enforcement or child protective services. And so that's part of why we can do the research that we do here, and part of why we're able to universally screen all of our patients for substance use during early pregnancy. Unfortunately, the laws are not always consistent, and I don't think patients know that. So there are some states where cannabis is legal for adult use, but it's still penalized or criminalized if you use during pregnancy. And so I think it's important to be aware that just because it's legal at the state level for adult use doesn't mean that there's not punitive policies for using during pregnancy, which is what many patients think. Now, in California, it turns out that that is true, but I think it's important to keep in mind, and we'll talk about that more. And the third and final thing that we got out of these focus groups related to legalization was that our pregnant patients just have so much trust in cannabis retailers. They trust in the safety of cannabis products. They think if it's sold at a cannabis retailer, it's safe for use during pregnancy. They really appreciated the diverse product selection. And so they felt like no matter what kind of ailment they had during pregnancy, there would be something that would be able to help them. And they viewed the staff as knowledgeable and caring and non-judgmental. They really valued their opinion and felt like they were quite supportive of cannabis use during pregnancy. So this patient says, if you walk in there pregnant, they're not going to be like, oh, you shouldn't do it. They'll show you what would be best for you during your pregnancy, depending on your symptoms. And another said they care about you. It's kind of like the doctor. And this is really important because many of our patients equated bud tenders, or those who work in cannabis retailers, to physicians, with some believing that they received medical training or at least some training, when in fact in California, there is currently no required training whatsoever for those who work at a cannabis retailer. And so this trust in bud tenders is really concerning because there's also some evidence that they may be recommending and promoting cannabis as safe for use during pregnancy. So I want to share with you this study that was done in Colorado. It was a really interesting study. They had a research assistant call cannabis retailers and say that she was pregnant and in her first trimester and had morning sickness, and asked what they would recommend. And in this study, 69% of the cannabis retailers recommend cannabis for morning sickness, saying, yep, this is going to help you. It'll be helpful for your morning sickness. 31% said, yep, no problem. It's totally safe for use during pregnancy. And only 3% said you should speak to your clinician without being asked, just on their own, said, yeah, you should talk to your doctor. Only 3%. So this is quite concerning. So now we're going to move over to talk about, well, what do we know about the health risks of cannabis use during pregnancy? And we know that cannabis may be harmful to the developing brain because it disrupts the developing endocannabinoid system, which plays this really critical role in shaping brain development from conception all the way into adulthood. And this includes the neural circuits that are involved in learning and memory and decision making and emotion regulation. And we now know that prenatal cannabis use is consistently associated with increased risk of offspring low birth weight, small for gestational age, preterm birth, and admission to the neonatal intensive care unit. There is some evidence that it's also associated with attention and externalizing problems in childhood, and I would say really less evidence at this point that it's associated with other behavioral and cognitive outcomes. And one of the best studies that have been done looking at this question, the data come from the Adolescent Brain Cognitive Development, or the ABCD study. And this is the largest long-term study of brain development and children's health in the United States. So these children are born between 2005 and 2009. And this particular study was done by researchers from Washington University in St. Louis. And what they found in their study was that prenatal cannabis use that continued after the mother learned she was pregnant was associated with increased risk of attention, social, and behavioral problems in offspring all the way into early adolescence at ages 11 and 12. Now, what was interesting was that if the person used cannabis use during pregnancy but stopped as soon as she learned she was pregnant, they did not see a significant association. So this may speak to the heaviness that people are using, or maybe the importance of different trimester of exposure. We don't know, but that was an interesting component of that work. Now, even the ABCD study has limitations. So, for example, in that study, they had maternal or caregiver retrospective self-report on cannabis use during pregnancy from 10 years earlier, which is not ideal. And many of the studies that have been done to date have relied on self-reported use. They often don't account for co-occurring substance use, oftentimes don't look at frequency. We'll talk about this in a minute, but we don't know of any studies that have really looked at whether the mode of use matters. Many of the studies have been with small samples and older data. And so we have been arguing for the need for better data because pregnant people want to know what are the risks, and we want to be able to give them those answers. And so we were fortunate to receive 3 R01 grants from NIDA, so large funding from the NIH, to study the health impacts of prenatal cannabis use on mothers, babies, and children later in life. So I'm going to share two studies that we've published recently. This one was published at the end of 2023. And we wanted to look at prenatal cannabis use and adverse neonatal outcomes in our sample. So we had a huge sample of over 360,000 babies born from January 1st, 2011 to July 31st, 2020. And their mothers were all screened for cannabis use during pregnancy by self-report and toxicology testing. We found that 6.2% of them were exposed to cannabis based on maternal self-report or toxicology testing. And we found that adjusting for a number of covariates, prenatal cannabis use was associated with significantly increased risk of low birth weight babies, small for gestational age, preterm birth, and admission to the neonatal intensive care unit. So these are not new findings. These are what other people had found before, but it was really good to confirm these findings with this huge sample that also include biochemically verified data on use. So the study design was an improvement, and we were seeing similar things to what have been found in the past research. Something else that we were able to do is, because we asked patients about their frequency of use, we were also able to look at whether the frequency of use matters. And what we found was that there's an increasing likelihood of both low birth weight and small for gestational age that's associated with increasing frequency of prenatal cannabis use. So as the frequency that the mother is using during pregnancy increases, the risk of these negative outcomes increases as well. The next paper that we published just at the end of 2024 looked at prenatal cannabis use and maternal pregnancy outcomes. And we thought this was important because most of the work has focused on the impact of prenatal cannabis use on the child. And we were curious to know, well, what is the association with health risks for the moms themselves? And so this paper was published in JAMA Internal Medicine. Again, we used a large sample of pregnant people who were screened for prenatal cannabis use. In this study, 6.3% of them screened positive for cannabis use during pregnancy. And we found that prenatal cannabis use was associated with a greater risk of gestational hypertension, preeclampsia, excess weight gain, and placental abruption. And so very few studies had looked at these outcomes before. And so we need more work that looks at the health of the mom, but we thought that this was important, that maybe the impacts are not just on the baby, but also on the pregnant person herself. So our work, as I've mentioned, overcame a lot of the key limitations. So we had toxicology testing and self-report. We used more recent data. We were able to look at frequency and adjust for important covariates based on data from the electronic health record. And we also did a subset where we looked just at people who used cannabis only and did not have any other substance use as a way to try to get at whether this is actually due to the cannabis or other substances. And even in those sensitivity analyses, we saw similar results. So some of the next steps for our research, we're going to be looking at prenatal cannabis use and fetal loss, birth defects, developmental delays, and offspring psychiatric conditions. And I want to point out that we also have several papers that have come out recently that have looked at prenatal cannabis use and offspring outcomes later in childhood. So we're seeing really strong associations with risks for mom and babies during pregnancy and around the time of delivery. But when we've looked later out into childhood, we actually have found that prenatal cannabis use has not been associated with increased risk of things like autism spectrum disorders, ADHD or conduct disorder, or hearing loss. And one of the things that patients want to know all the time is, does it matter how you use cannabis? Does it matter if you smoke or vape or use edibles? And as of now, we really don't have a lot of information about how pregnant people are using cannabis or whether the health risks vary. And so we were able to work with our clinicians and leadership to convince them that we really need to be asking not just about whether patients are using cannabis in pregnancy, but also about how they're using it. And so we pilot tested a screening questionnaire that asked about modes of administration. That went well. And then we were able to roll out this question across the Northern California region. So now we're screening more than 50,000 patients a year, not just about their use, but also about their modes of use, both for the time period before the year before pregnancy, and then also during early pregnancy. And so here are some data. These were just published in 2025. And you can see that the dark blue is the year before pregnancy and the lighter blue is during pregnancy. And you can see that among patients who use, smoking is still the most common mode of use, followed by edibles, and then vaping, then dabs, and then topicals. We also specifically query about smoking blunts, even though it is a mode of smoking, just because a blunt is a cigar that's been hollowed out and filled with cannabis. And so you're getting both the tobacco and the cannabis. And so we're particularly concerned about this. And we were surprised to see that the percentage of our patients who use cannabis who use blunts is pretty high. So 32.7% during the year before pregnancy, and nearly 30% of those who use during pregnancy are smoking blunts. We also found that most patients are using more than one mode. So 59% are using more than one mode before pregnancy and 48% during pregnancy. And when we talk to our patients, they asked for information about which modes are most harmful or safer. They all had different ideas about which ones might be. Some thought edibles would be more harmful. Others thought edibles would be safer. Just a lot of questions and uncertainty. And this patient said, we don't know the risks between all of them. Could one mode be worse than another? Sure, I mean, definitely, but we just don't know. And they did tend to prefer modes that they viewed as safe, although what they viewed as safe could vary. They liked things that were convenient and then also effective for helping them with their pregnancy symptoms. And so we were able to get a new grant that's going to now use the data that we have on modes of prenatal cannabis use to look at how they relate to other prenatal substance use, maternal health conditions, and then also things like local policy and cannabis retailer data to see if the modes that people use vary depending on the local cannabis policies and context. And eventually we'd like to get funding to do a study to look at modes of prenatal cannabis use and neonatal and offspring outcomes. All right. So now let's move to how to talk to pregnant patients. Pregnancy provides this unique opportunity to provide care for people who may not otherwise see a clinician. And pregnant patients we know are motivated to improve health behaviors for the benefit of their baby. So it's a really important time. So I want to acknowledge Tara Foti, who's a postdoctoral fellow who worked with our team, and she led this paper that was published in Obstetrics and Gynecology, where she put together recommendations for how to talk about prenatal cannabis use based on what we heard from our patients who use cannabis. And so I'm going to go through these and then we'll talk about this in more depth. So the first recommendation that our patients have is just to remember that they have reasons for using, and it's important to them that their clinicians try to understand them. So this patient says, teach doctors how to bring cannabis up in a way that isn't judgmental, just an open, confidential conversation with their doctor. There's no judgment there. It's also really important to listen, to hear why they're using rather than just saying, don't use, all use is bad. If patients are experiencing benefits of using cannabis during pregnancy and their doctor just says it's black or white, using is bad, there's no way it's giving you any benefits, they tend to stop listening. And so this patient says, I want to explain to my doctor what the cannabis benefits are and why I prefer it over prescriptions that she wants to give me for my pain. It's also important to have a dialogue to make it a real conversation and not just a lecture. So this patient says, my doctor asked a lot of questions and listened and made me feel very comfortable. It's helpful to acknowledge the patient's perspective. So the patients want to have their physician or their clinician reflect back to them that they've heard why they're using and acknowledge their perspective. So this patient says, know that whatever choices I make, I use cannabis because I believe it's the best choice for myself. Now, once the listening has been done and the patient feels heard and understood, then it's a really great time to provide that education. And so we can provide non-judgmental education to our patients about the health risks of using cannabis in pregnancy. This patient says, give me the health benefits of it and the cons of it so that I can make an informed decision on my own. And then finally, it's so important to recommend quitting and to support and praise people who are able to stop. And so this patient says, having somebody to be like, I'm really proud of you, we're cheering for you, that made me feel good. If the patient's not willing to quit, you can provide them with alternatives like using less frequently or potentially switching to non-smoke modes, giving them referrals and resources and other options that might be helpful to them. So I'm going to end with some final thoughts and then we'll have some time for questions. And so one of the things that I want to point out is that we're very mindful as researchers about the role of the researcher, and our studies get a lot of media attention, and we have to be so careful that the data that we present are not used to penalize pregnant people or to reinforce punitive laws. So we're very mindful of the potential of our research to both help and to cause harm. And we're working to change this culture of punishment to one of love and dignity. When we present, we try to have a sentence, all of our sentences really carefully crafted, and always have a disclaimer about research not being used for harm. In 25 states, prenatal cannabis use or substance use in general is considered child abuse. In 3 states, considered grounds for civil commitment, which means that a pregnant person may have to go into inpatient treatment against their will. And in 25 states, they require reporting of prenatal drug use. Now in California, as I mentioned, clinicians are not required to report to law enforcement or social services, which is why we're able to screen our patients in the way that we do, both because of our non-punitive policies, but also because we have our early start program. So we're not just screening to find out whether people are using and then doing nothing or punishing them. We're screening in early pregnancy so that for those patients who are using, we can work with them during their pregnancy to help them quit, so that they can have a safer pregnancy. And we do know that punitive state policies are actually not helpful, and the research shows that they've been associated with decreased odds of prenatal care and worse neonatal outcomes. So what they have been shown to do is not to help people stop using substances, but it makes it more likely that they don't come in for care at all and has been associated with worse outcomes. So my colleagues and I have published on this topic in a paper called Moving Towards Health and Social Equity for Women Who Use Cannabis During Preconception, Pregnancy, and Lactation. And in this article, we say, now is the time to reform antiquated policies that criminalize prenatal substance use in favor of focusing on protecting the health of mothers and their children and ensuring equitable access to supportive and non-punitive substance use treatment. And, the American College of Obstetricians and Gynecologists has also said that we need to get away and be done with these punitive policies. So there is, kind of national support for this concept, and the research has really been consistent that it's not helpful. So It's a good reminder that once CPS has been called or Child Protective Services, it does go in someone's file and can impact them later. And so for those of you, if you have to make a report because of policy or mandated reporting, but you don't actually have concerns, it's really important to document that. So to put that in your report and say, you know, I'm reporting this because I have to, but I don't have concerns. And also to be upfront with the patient about what you found and what you're going to say in the report. Be honest, let them know that you don't have anything to hide. And I think it's also very important to let patients know in advance what the reporting requirements are, because it's also possible to have these conversations about what the risks are in a non-judgmental way and to provide resources for mental health without having to have the patient specifically tell you if you're concerned about having to report. And then this is a final slide. This was provided to me by Mishka Turplin, who's a wonderful colleague. Is a slide he presented. I thought it was interesting. It showed that most child welfare reports are from the medical professionals during the birthing hospitalization. So at the time of delivery, we're seeing these really big increases in reporting over time. And we see that it varies by the race and ethnicity of the mother. Oftentimes driven by use of urine drug toxicology testing at delivery, which is not actually recommended. And you can see that this compounds racial inequities. So with that, I just want to thank all of my collaborators. It's a lot of people who have contributed to this work, all of our funding, and then I am happy to take questions.
Thank you so much, Dr. Young-Wolf. We have a couple questions in the chat. Elizabeth wanted to know, does Kaiser Permanente include Medicaid patients through Medicaid managed care?
Yes, we do have Medicaid patients.
Great. And then, this question for Cynthia is one I can answer, but Cynthia wanted to know if the presentation will be shared and provided her email. Yes, the presentation will. I will send the slides out after, and we have been recording this, so it'll be a couple weeks before it's up on the MESUD website, but it should be up on the MESUD website soon. So if you want to share it with your colleagues, you will be able to find it there. Sorry. And then Emily was wondering if there are any studies done on secondhand cannabis smoke on fetal development.
That is such a great question. Not that I know of. If there are, they're very few. So definitely an emerging area, but we do have concerns to think that the impacts of cannabis secondhand smoke could be similar to those of tobacco smoke. And so interestingly, when we talk to our pregnant patients, many of them actually said that they're taking steps if they are planning to use after they deliver the baby. They're already planning things like, I'm going to switch how I use. I'm only going to smoke outside. I'm not going to smoke near my baby. And so I think it's something that's on the mind of pregnant people and postpartum people, but I don't think we have really good data yet.
Thank you. Another question kind of related to partners. As we learn more about the health status of fathers affecting health of newborns and children, are there any studies on fathers' cannabis use affecting sperm or future health in the children?
This is also a really great question. It's challenging to study because we don't have as much information about father's use, especially via things like toxicology testing, right? But there is evidence, I believe, that father use or male use of cannabis impacts sperm and it can make it harder to get pregnant. But in terms of the impacts of paternal cannabis use on the offspring, really less is known. I think we're going to hear more and more as time goes on.
Great. Kaylee wanted to know if you had any information on the main regulations around around prenatal cannabis use.
You know, I don't know, but I can send when I send my slides, I'm going to put in a link to where you can look up all the information for all of the states. So I'll make sure that's in there.
Thank you so much. I'll take this opportunity as if there's any more questions, please place them in the Q&A function, but I'll take this opportunity to share that the survey link is in the chat under my colleague Casey Coder graciously asked a question that the answer is the survey link. And also you can look forward to, we have another pregnancy related webinar coming up on was March 18th from 2 to 3 p.m. on buprenorphine induction and pregnancy. So that link will be shared in the follow-up email. Oh, we have some more. Laura wanted to know, what are your thoughts on the universal drug screening in pregnancy? It sounds like it's a practice at Kaiser. I understand that it's a controversial subject, though I don't fully comprehend why. And what are the guidelines for universal screening?
Yeah, that's a great question. So, universal screening by self-report, especially in early pregnancy, is recommended, including by the American College of Obstetricians and Gynecologists. However, screening by toxicology testing universally is not recommended, and especially not recommended at delivery. And so, in states where cannabis is not, they're not punitive policies, especially in conjunction with a good intervention program, we are able to do toxicology testing, but we're not doing it universally at delivery. We're doing it early in pregnancy where there's time to then help people. But the goal, it's really the goal of is not for research, it's not to punish people, it's just for helping people to be able to stop by connecting them with people who can help. And so I would say that it kind of consistent with the national guidelines is that we don't recommend universal toxicology testing in states where there are punitive policies, and we don't recommend universal toxicology testing at delivery.
Thank you. Kathy wants to know if there's any studies on cannabis use in breastfeeding.
Oh my goodness, you guys are asking the best question. So that is a wonderful question. There really is almost nothing known about cannabis use and breastfeeding. What we do know is that there's been a few studies done. They're old with older data when the strength of cannabis products was less. And what we think is that cannabis can actually stay in the breast milk for up to 6 days. So it has a longer time period than something like alcohol. And so when people try to do like pump and dump from using cannabis, it's not going to work because the cannabis will be in there for many days. Now, in terms of the impact of cannabis use on breast milk and on the child, we know that the cannabis does go into the breast milk, but we don't really know what the effect is on the baby yet. So there's just been too few studies with too small of sample sizes. And so one of my goals for the future is to try to look at that using a bigger study so we're able to appropriately advise pregnant people. I think the national guidelines right now say that it's important to try to stop using cannabis when you're breastfeeding. So they advise to not use while breastfeeding. However, they say that the benefits of breastfeeding are so great that if someone is not willing to stop using cannabis, they would still recommend breastfeeding over not. And so I hope that makes sense. So the goal would be not to use cannabis while you're breastfeeding, but if you're going to use cannabis, they still recommend breastfeeding just because of all of the known benefits of breastfeeding.
Great. Yeah, I'm excited to see what the future holds for that data. And Emily wants to know the data that you referenced today, is that available for the participants to look at, and where would they find it?
Like the different studies that I went over, I'm assuming you mean? Yes,
Yes.
those should be all publicly available. We'll send you the PDF of the slides and you can see sort of like the name of the journal and the year. And if you go onto PubMed or Google Scholar, you can just put in Young-Wolf, my last name with 2 Fs, and you can see all of our whole body work on this topic, and you would be able to search for the specific papers because it's too many to send out. I think I probably talked about a ton, but you can find them all there on something like PubMed.
Great. Thank you. And I think if there are any other questions, please place them in the chat right now. Or if you think of a question later, you can email it to me and I can forward it on to Dr. Young-Wolf. But thank you so much, Dr. Young-Wolf, for this wonderful presentation. And thank you everyone for joining us today. And we hope to see you all again soon.
Great, thank you. Thanks for all the really good questions.
Yes, thank you, everybody. Those were great questions. But yeah, thank you and see you soon.